Thank you very much. Good morning, and thank you to those of you that ventured in early this morning. It's very kind. Maybe a few more people will come in as the day goes on. And maybe I just spare a moment to think of our colleagues in Sri Lanka this morning as the work unfolds. So some of us are looking a little bit jaded, and apologies if we feel a little bit absent, but for those of you that know our work, we have the opportunity to collaborate with many people, but our home and colleagues is Sri Lanka, so we look forward to being back there in the next day or so. Okay, so I was very kindly invited to speak this morning on how our experiences of addressing the quality gap that exists in care internationally, I think it's reasonable to say. It's a universal challenge. It is not limited to resource-limited settings, and perhaps increasingly for all of us, trying to think how we can improve quality of critical care is something that's at the forefront of our minds. It's just that the goalposts move regardless of where you sit on that spectrum of learning. And this is a little bit of our experience of how technology can perhaps help that. And I do have some specific examples, but it's a relatively high overarching approach, so it should be quite light for the morning as we wake up, and I hope that's all right. So a quick recap for us. Improving critical care, the challenges, we know this, is global burden of critical illness. There's relatively limited investment in health system level infrastructure, and it's a big challenge, and I think it's worth just taking a second to define it in my mind, and it's a question for you to consider. There's a difference between saying there's a lack of resource and there's a lack of investment in health system infrastructure. I think the two are quite different, and they can coexist, and they can also be very separate. What do I mean by that? It's very easy to be on a ward or in a clinical ICU and not have the resource or equipment that you think you need. You can still have investment at government level in health system infrastructure. It is part of a journey. You can simultaneously have lots of equipment, and I've worked in many settings where we're quite resource light, and they have lots of fancy equipment, but there is no investment at infrastructure level. And that really means, for me, what that means is the underpinning ability to learn from the care we deliver. So some people call that a learning health systems approach. That's sometimes up for debate, but it is the ability to measure and report information and evaluate the service we provide, and use that information as a springboard to make our services better, perhaps at the macro level, not just the micro. Okay, so we have complex processes of critical care, often disrupted by bottlenecks in both service delivery, in referral, in communication and transfer. And as I've said before, this lack of investment in infrastructure, so macro level systems, is often disraced or disrupted by the fact that there's a lack of information. And that disables people from being able to evaluate care. It also disables ability to evaluate service provision and make decisions about future direction and devolvement of services. And it also disrupts individual patient care right across the critical care spectrum. Information variability and reliability can be variable, and there's very little information about what we might think of measures of quality. We talk about improving quality, but what is that? And for many of us, that is increasingly beyond that kind of traditional Donabedian model of infrastructure, process and outcome, and needs to also include patients and what they want and what their priorities are for the communities in which we work and serve. And there is limited information to support research, we know. Okay, so I move on a little bit. So what did we think we would try and do? Well, we were a little bit struck with my colleagues in Sri Lanka back in 2012-13 about this limited information and ability to have health system level information for infrastructure. And we really thought technology could help. I finally got there, that's the name of the title. So how did we think technology could help? Well, we thought that particularly in South and Southeast Asia where we're based, technology is one of the most rapidly growing sectors of our services there is. It has revolutionized banking. It has revolutionized social communication. It has revolutionized education. It hasn't done so much for healthcare yet, but if the methods of technology, whether that's mobile platforms, internet communication, can exist and exponentially rapidly grow in those settings, why can't it help healthcare? So we set out on a process to try and see whether a technology-based system, cloud-based system, could improve the availability of service-level information to inform and assess and evaluate critical care. And I'll come back to this slide a little bit. So we tried to set up, I think, what we would traditionally call a critical care registry, and that was around in 2012 with Rashan Hanifa as part of his PhD work and a set group of clinical colleagues based in Sri Lanka in partnership with the Ministry of Health. It's a collaborative approach to the design of this cloud-based system, and it, as I said, was to enable the implementation and evaluation of service-level patient care. The process had to be collaborative and open. If any of you have had the pleasure of speaking to colleagues such as Dave Pilcher when they present, or from the ANZICS core group, or from Kathy Rowan from ICNARC, you will hear their journey of how the work is incredibly long and arduous to establish information systems in settings, whether that's with or without technology, and the fact that it must require stakeholder engagement and a communication across the shareholders of critical care, from everybody from ministry to policymakers to administration to our clinical care providers and colleagues, and also our patients and their families. So the approach we took was to be cloud-based. It's an electronic open source platform. It's initially was a data capture and collection tool. Nothing very exciting about that. We'll try and talk a little bit about the journey it's evolved on and how it's been used. And I think most of us are relatively familiar with registries, and Madiha also described very nicely the registry model that's now being implemented in Pakistan, and similarly in India as well, and we hope in some other settings soon. It has offline and online functionality. Well, that's great. Technology is readily available. It's open source. It's app-based. It's nothing particularly complicated for those of you that like a little bit of coding, and it's a constantly evolving and adaptive system. I think its uniqueness and its opportunity lies in its adaptability and in its ability to overcome some of those barriers that we've described of being able to measure and use information. But perhaps because the biggest opportunity technology has is perhaps not to be able to just capture, but help us integrate information in a very immediate way into how we think and make decisions about critical care provision. So how have we done that? Well, just a quick slide. This is a little bit of a high-view schematic of what we have. You'll see there, perhaps, I think on the top left-hand side of your screen, that it's mobile or desktop system. So this is enabled to be used on your average Android phone, of which there are about 1.6 per person in most of South and Southeast Asia. So how many phones do you have, Dr. Kim? I only have one. Ah, you're behind the curve, sir. So for those of you that don't have more than one phone, this is your opportunity. It then has internal storage. And what that means is that this can, in fact, be housed at facility level. So you can be part of a cloud-based network of information, but your information is still hosted and housed in your home institution. And that's incredibly important for us, as those of us that are trying to use information and technology in healthcare, we must be adaptive in order to be able to respond to the changing environment and political climate of information and governance. And I see that as a growing work, not as a finished solution. I definitely don't have the answers, but we're definitely learning how to adapt and respond to that. And again, it requires collaboration and conversation. It then does link to a central server where anonymized, aggregated information is available. And this forms what you and I might think of as much more of a traditional repository level data, so that we can look at aggregate comparisons. And some of that's work in progress. The next part is the use part, the interesting part, I think. This is where my interest bit lays. It's in the ability to analyze information. And through a little bit of simple visualization and analytics, we're able to make facility level information, scalable to regional level information, visible to people back in near real time. So what does that mean? Is that if you are working in your ICU or in your acute care setting, you can actually have the patient level information, granular level information, fed back to you, synchronized between you and your team members with about 5 or 6 seconds delay. Within 24 hours, you can also have that information available at aggregate level. That's very exciting, wonderful, it makes it visible. It must always get better, but then we have to try and use it. So that's then the challenge. So how do you then get people to use such information? So a quick scope of where we're learning and where our journey is at the moment. And as I mentioned in Sri Lanka in partnership with the Ministry of Health, there is now a national system for critical care, and I'll show you what that does a little bit for people shortly. It also works outside of critical care in acute care settings as well, and has quite a few patients within the system, but this is aggregate level information, varying availability, and it measures everything from pre-admission and access to acute and critical care, and also includes some elements of post-ICU, post-acute care discharge, recovery and follow-up. Some of this information is considered service level, some of it is part of ongoing research collaborations with the ministries and with particular groups of clinicians, and then appropriate ethics, etc. is applied for that as required. So it requires a mixture. That data isn't cohorted together, it is separated out, but you can view the aggregate components of that if you need. So then we need to look at how this can start to overcome those challenges. So the first thing I think we mentioned was about assisting with access to care. So this is a little video. I don't know if it will play. Maybe it's not going to play. We can ask the nice colleagues at the back. If it does, that's great. If it doesn't, you're not missing too much. This is a dashboard of systems where the registry service information is enabling access to ICU beds in the region. So in around 2013-14, we started to use some of that information on admissions, discharges, occupancy to help inform regional and national bed availability. And with a team of colleagues in Sri Lanka who work for the Ministry of Health, the country now has a 24-hour national bed availability system where live information on bed access and occupancy is available, and clinicians working outside of ICU can contact a central telephone repository system to identify where the geographically nearest bed for their speciality might be. And so far the team and the system, in partnership with the ministry, have found around 6,000 beds for patients within critical care. And it also enables us to go on to look at that in terms of occupancy, access, equality and access equity of services within the region. The next part is a little bit about assessment of quality, not improving quality, but assessment of quality of care. And this is a snapshot from one of the acute care parts of the system that works within cardiology with our friends from the Sri Lanka STEMI Forum, and thank you very much for them for sharing this screenshot. Again, aggregate level information now, but it is available as individual patients for those clinicians. I'm not showing you that. This is just the aggregate screenshot that's used as a dashboard displayed within the region's only national 24-hour PCI centre, which has been a huge investment by the government to try and improve access to AMI care for patients. And for those of you that know a little bit about South and Southeast Asia, cardiovascular disease is one of the most prevalent causes of mortality in the region. And what it does is it provides service level information, so admissions, activity, a little bit about some measures of quality indicators, and you'll be very familiar with those, they're pretty standard, including some measures of patient satisfaction, and it also describes some information about outcome. Okay. So then how do we close the gap with information for frontline care? So anybody that had the pleasure of chatting a little bit yesterday, I tried to convey in a clumsy way a little bit about how we use the system, the platform in a very granular way with nurses and healthcare workers working at a ward level to try and improve availability of information. So again, this is not a before-after, this is not science, I said this was high level. This is a little bit of trends in information for acute admissions to wards in hospital settings where we have the pleasure of doing some locally based hospital-led projects. And these for people who wanted within their wards to improve information availability on vital sign reporting. And you can see a snapshot there of heart rate and respiratory rate, which was selected by the clinical team of being key measures of enabling people to detect deteriorating patients. And you can see how having a visual representation of what's being reported in itself appears again, I'm not quoting this as research, appears to have increased availability of some of that. And I think actually more than that, it empowers those clinicians to understand what is and isn't being available in their ward. And it also helps them understand information such as their occupancy in the ward, their nursing to patient ratios, and how those kind of service level activity can make changes to the care that they're able to provide. It's had an impact at perhaps trying to develop new roles for nurses and allied healthcare workers. And I think this is quite exciting, and maybe something that if anybody wishes to chat about afterwards, happy to do. So the ability to have mobile access to information means that all of a sudden people can have access to all over the hospital, and they can make information communicable from one department to another. And this is a role so a rapid response nurse, for those of you who are familiar with thinking about the roles of outreach and prevention and ICU admission avoidance, or reducing delays in admission. So in a couple of hospitals we work, nurses have wanted to take the platform and use it as a way of going out and visiting patients, collecting information and being able to visualize that information and share with colleagues in the ICU, in the radiology department, in the clinics where their doctors and consultants might be based. Because if those of you that are familiar with working in some hospitals in the region, the geography and the environment makes delays in that movement of information and in escalation of care quite a challenge. It has enabled research. It's a little bit of early work looking at prognostication of modelling for critically unwell patients. It's a snapshot. There are many more and many others underway. It also enables us to understand how patients are recovering from critical illness. This is a little snapshot, again, with the permission of our colleagues within perioperative medicine, looking at just over 1,000 patients and measures of quality of life and recovery. Again, they're high level, they're granular, they need further investigation to interpret. And we don't see the platform as being able to answer specific research questions directly. It's able to provide a signal of which you are then able to focus your attention to go on and see where a gap in care might be and how you might want to undertake a more narrow evaluation and improvement of the critical care services. And finally, it's also starting to include patients. So this is just underway. It's certainly not rolled out. We're in the testing phases of seeing how patients might use the platform, a little bit of technology to report information. Because these patients, many of them that perhaps, for example, elective surgery patients, are able in part of their recovery process to use phones. They're using so to communicate with their families. They would use so to communicate with their doctors, with their nurses and with their colleagues. And they're also able to report some measures of how they feel they're doing. And we would like to see, and we would love to know your thoughts on whether this can also help enclose the gap, not only in being able to find patients that need assistance after critical illness, but also being able to understand what their needs and what their journey into recovery is, and that how we might better understand the impact of critical care on our patients, and also what priorities they have for recovery. Okay, so I think we've also had the opportunity to adapt technology, to be able to use this system of information capture, analysis, and visual feedback to other specialities. And one example is a collaboration in Sri Lanka with colleagues working in primary care and public health as a platform that's used nationally for rabies management and prevention, which any of you know Sri Lanka has a very strong primary healthcare system, something it should be very proud of in the region. And it does a lot of work to manage such diseases such as rabies with big inoculation programs, but it also recognised the need to be able to act and respond to patients that got bitten. And as part of their vaccination program and treatment patient for post-exposure prophylaxis, they used the platform to not only monitor patients' adherence to the cyclical access to vaccination, but also to look at histology reporting and outcomes. Were there any challenges in doing this? Yes, there were many, and many still remain. And we are very much learning with our colleagues, both regionally and internationally, how to do this. Some of the barriers are overcomable, and most of those are about technology. There is, in my experience, with the caveat to be able to change my opinion, no reason why technology can't be used in healthcare. We use it all the time. Anybody wish to put their hand up if they use WhatsApp to communicate during clinical care? I know I certainly do. So if WhatsApp can work, then maybe we have a little bit to learn about health informations can get better. The challenges for us remain in behaviour and culture, and by that I do not mean geographic or regional culture. I mean our culture of healthcare, which I think is increasingly universal and comparable. We are resistant to change. We do struggle to understand how we can use information better, and we are, each of us, understandably anxious about how information can be interpreted and how we can better use it to make change. And it can sometimes threaten the status quo of what we understand to be or what we feel is good care. The suggestion I would put to each of you that feels those anxieties, and I do also, is that actually, if the information is in our hands or your hands, then you are the people leading that change, rather than the people being told what the information tells you. And for me, that is the greatest opportunity. So in summary, a little journey of our network of how we might use technology to improve healthcare. I think we've run through these. So started with an ICU registry in Sri Lanka, has grown to provide a bed availability system, information for epidemiology, primary health and service planning and provision. It incorporates patient experience and increasingly incorporates clinical information from a setting level, so it's not national, it is with the permission and with the understanding of research and ethical and governance within clinical settings, and it provides measures of quality and performance. And we hope that the future looks how we can now start to learn to use these very separate, discrete components as a toolbox to improve critical care. Research is not quality improvement. Service evaluation information is not research. But there is overlap and there is overlay. And we can become more efficient, perhaps, with technology about capturing a little bit of information and using it more effectively, maximising how we can use that. And maybe there's opportunity to expand that regionally, internationally. Also think there might be a little place for patient wearable devices and how we might use that information. And maybe that can also help us with some of the challenges of overcoming human resource and our disparate health systems as investment in infrastructure grows. That's me. Thank you.